Cushing syndrome and adrenal insufficiency. Do you see my screen?
Yes, ma'am.
First of all, as usual, normal physiology, parts in adrenal glands, adrenal medulla, and adrenal cortex. So adrenal glands, two parts, two autonomical parts, adrenal cortex and adrenal medulla. Adrenal cortex, it is an organ, endocrine organ, which is developed from endotube due to the embryogenesis. It is developed from endogen tube. Medulla developed from nerve tube because medulla it's a part of the nerve system. So medulla, that part of adrenal gland, produces epinephrine and norepinephrine. You see how it is regulated. Sympathetic nerve impulses stimulates medulla to produce epinephrine and norepinephrine, not pituitary gland. Pituitary gland does not activate production of epinephrine, norepinephrine, only nerve impulses. Then cortex. Today I will speak most about cortex. There are three layers in cortex: zona glomerulosa, zona fascicularis, zona reticularis. Zona glomerulosa secretes aldosterone. Look on the left part, which stimulates aldosterone, angiotensin 2, which stimulates aldosterone, renin. Then zona fascicularis and reticularis produces mostly cortisol and androgens. What stimulates cortisol and androgen secretion? ACTH, adrenocorticotropin hormone, hormone in pituitary gland. Come back to that picture. Adrenal hormones hormones of the cortex, they are steroid hormones. We also call them steroid hormones. All previous hormones, which we discussed previous classes, the parathyroid, thyroid, and pancreas, these hormones are protein hormones, amino acid hormones. So amino acid or protein hormones, because pancreatic hormones, they are proteins. Parathyroid and thyroid hormones, they are amino acid hormones. Adrenal hormones are steroid hormones, the hormones of adrenal cortex. We also have another steroid hormones in testicles and ovaries, like estrogen, progesterone, and testosterone. All them are secreted from cholesterol. So here you see various all stages of secretion of steroid hormones of adrenal cortex from cholesterol. With the red color mentioned enzymes, which play the role in regulation. If you finish pediatrics endocrinology, there you had a topic, congenital adrenal hyperplasia. It's a deficiency of enzyme P450C21, which play the role in conversion of progesterone to cortisol and aldosterone. These children, they have adrenal insufficiency usually from childhood. There are so many enzymes, and these enzymes regulate secretion of cortisol, aldosterone, and steroids, androgens, so androstenedione. ACTH regulates, as I said, cortisol and androgens secretion. It does not regulate aldosterone secretion, or this regulation is a very few. So once again, if you look at the zones of adrenal glands, zona glomerulosa, it's the first zone. It produces mineral corticoids, aldosterone. Why do we call it mineral corticoid? It regulates sodium and potassium balance. Sodium-potassium balance, that is aldosterone, because it regulates potassium and sodium. We call it mineral corticoid. Zona fasciculata, adrenal cortex. So again, corticosterone, cortisone. Why we call them glucocorticoids? Zona reticularis, adrenal cortex again, androgens, dehydroepiandrostenedione. They regulate masculinization, mostly in females, but in males also in climacteric period and in childhood. So the need of androgens is high in both sexes. And adrenal medulla, it's not a cortex, it's another gland. It is an autonomical part of adrenal gland which does not depend on pituitary. It is a stress hormone regulated by sympathetic and parasympathetic impulses, mostly by sympathetic. What is the effect? Right part of the picture. So cortex, adrenal cortex, you see pituitary gland produce ACTH. ACTH stimulates glucocorticoids, mostly less mineral corticoids. Mineral corticoids are part of the RAS system. Glucocorticoids are long stress effect. They affect protein and fats broke down and converted to glucose. That is their basic influence. And they also suppress immune system, our own immune system, because our immune system could be very aggressive to the own cells. And that's why we have corticosteroids, one of the mechanisms of suppression of immune cells. Why we can use the medications on the basis of corticosteroids in treatment of various autoimmune disorders, especially reaction, if it is reaction of hypersensitivity number 1, if it is type 1, in people with the various types of allergies, and if it is anasarca or due to the Quincke syndrome, etc. Mineral corticoids, retention of sodium and water in kidneys, and those also increase blood volume and controls blood pressure. Adrenal medulla, left part of the picture. Nerve system regulates secretion of epinephrine, norepinephrine. It's also broke down glycogen to glucose, increase blood pressure, increase breathing rate, but do it very quickly because it is a short-term stress response. They are responsible for flight or fight reaction. That is your second semester, if I'm not mistaken, topic, renin, angiotensin, aldosterone system, how it is regulated, kidney, lungs, liver, arterioles, pituitary, ADH means in pituitary glands, peripheral kidney tubes, potassium, sodium, and water retention, depend on aldosterone, angiotensin, renin system. First topic is Cushing syndrome. So Cushing syndrome, that is what? That is the overfunction of pituitary or adrenal cortex with the elevation of cortisol. This is normal elevation, so normal regulation, as usual, positive and negative effect presence in all endocrine systems. So Cushing syndrome, situation when cortisol level increase due to the pituitary ACTH hypersecretion. Could be, or it also could be due to the glands tumors, also oversecretion. But if it is pituitary gland oversecretion, we call this condition Cushing disease. If it is extra pituitary, Cushing syndrome. It was discovered, or it was described by American author Harry Cushing, but if you open Russian literature, you will find that it has another name, Itsenko Cushing disease, because in Soviet Union also there was a doctor, Itsenko, who autonomically described that syndrome. So Harry Cushing, but in English literature everywhere it is called Cushing. He found that on autopsy of people with the specific symptoms, on the right picture, you see the woman. The symptoms of Cushing's are very special. Not any other disease will give you that symptoms. These people, they had tumors of pituitary gland. But then in the 20th century, in the middle of 20th century, end of 20th century, the theory of the Cushing syndrome was developed, and it was shown that patients may have 4 various types of Cushing syndrome. A first group of disease, ACTH-dependent Cushing pituitary adenomas or ectopic ACTH production tumors. 65 to 75% of tumors are pituitary adenomas. Pituitary gland produces too much ACTH. ACTH stimulates secretion of adrenal glands. And ectopic ACTH secreting tumors could be usually malignant, more aggressive, in peripheral organs like lungs, pancreas, liver, sometimes ovaries or testicles. ACTH-independent Cushing syndrome, adrenal adenomas and adrenal carcinomas. In this situation, the tumor in adrenal gland, it is not in pituitary, it is in adrenal. It produces too much cortisol, blocked secretion of ACTH, but we also see symptoms of Cushing. Pseudo-Cushing syndrome. Next slide, I will show you what's the reason of this pseudo-Cushing. And exogenous Cushing syndrome. Exogenous Cushing syndrome, it's a where we use corticosteroid drugs. So when we can use the drugs, we use these drugs in people with SLE, rheumatic fever, rheumatoid arthritis, liver cirrhosis, autoimmune hepatitis, people with the diseases of kidney, if it is autoimmune disorders like glomerulonephritis, chronic kidney disease, a lot of conditions we may see in people with where we may see situations where we need prolonged using of steroids, and in this case may present exogenous Cushing syndrome. So what is pseudo-Cushing? Pseudo-Cushing, it is a pathological condition where you will not see any pathology. There is no pathology, but may present symptoms of Cushing. When it may happen? Severe obesity, malnutrition, chronic exercises, amenorrhea, pregnancy, complicated diabetes mellitus. All these situations provoke chronic stress. Remember, cortisol is a hormone of chronic stress. And this chronic stress will activate formation of the Cushing syndrome. So, exogenous Cushing syndrome. As I said, it's people who take glucocorticoids for long period of time, as dexamethasone or prednisolone, long period of time, not a short period of time. They will have exogenous Cushing if dosage is high. Cushing disease, it is a condition when pituitary gland produces too much ACTH. It stimulates production of cortisol. Too much ACTH means too much cortisol. It's a tumor of pituitary gland. This tumor is usually small one, less than 1 centimeter. We call it microadenoma. If it is less than 1 centimeter, if it is more than 1 centimeter, we call them macroadenoma. Another type of Cushing syndrome is a ACTH independent or corticotropin independent. It is adenomas of adrenal glands, which produce too much cortisol autonomically, and so without secretion of ACTH. Symptoms, I will show you now photos. It's a really rare disease, but if I see it once, you will never mistake it. So 90% of people, they have weight gain because cortisol stimulates breakdown of protein and deposition of fats on abdomen and breast. Buffalo hump, it's a collection of fat on the back of the neck due to the cortisol influence. Round moon face, 90% of cases. Hypertension, 85% of cases. Cortisol stimulates glyconeogenesis. Remember the topic diabetes. So remember Tuesday lecture. Diabetes mellitus may develop due to the Cushing syndrome. We call this diabetes secondary diabetes, not type 2, secondary diabetes mellitus. It is a third group of diabetes mellitus, glucose intolerance in 80% of cases. Plethoric face, red cheeks, paralysis of versals due to Cushing. Purple striatus, a specific symptom on the skin, formatted lines, rashes, and these rashes are developed due to the destruction of protein in skin, thinning of the skin, and formation of that skin rashes. So hirsutism. If it is pituitary tumor, it will stimulate growth of hair because it also stimulates androgen secretion. And due to this, we may see menstrual dysfunction, muscle weakness, and easy bruising also present because of protein breakdown. Cortisol stimulates osteoporosis. 40% of cases in severe situations, the level, if cortisol is really high, people will have osteoporosis with vertebral and rib fractures. Thinning of the skin and mental changes in blood, possible to see immunosuppressive effect of cortisol like neutropenia, lymphopenia, eosinopenia. And in rare cases, may present hyperpigmentation if it is ACTH elevation. ACTH stimulates melanostimulating hormone. So that's a boy with the Cushing syndrome. You see here moon face. You may see here buffalo hump. You may see here obesity. Here you also see lines on the skin. So these rashes, red rashes on the skin, we are called them red striatus, more than 1 centimeter. So woman with the with the fracture of vertebrae, compressive fracture of vertebrae due to the osteoporosis in Cushing syndrome. Another picture with patient with buffalo hump and moon face. You see how they look like. There are changes in the specific changes in their vertebrae present and abdominal obesity. Also, white striatus, white purple striatus in Cushing. That is what findings in laboratory will see: hyperglycemia, stimulation of glyconeogenesis, hyperlipidemia, and changing in leukocytes, usually eosinophilia and thrombocytopenia. What we will do in diagnosis? First of all, we need to exclude steroid use. Exogenous Cushing syndrome, it's a situation when people use steroids. Then you will check urine cortisol during 24 hours. Then you will check early morning serum cortisol. And with the test, which is called low-dose dexamethasone suppression test, then you may check salivary cortisol and, of course, ACTH in plasma. What is low-dose dexamethasone suppression test? It's a test which helps us to differentiate exogenous Cushing, pseudo-Cushing from tumors of pituitary or adrenal glands. What do? We give, in the morning time, we measure cortisol. In the night time, we give 1 mg of dexamethasone. Dexamethasone, which is an artificial steroid. It will suppress the own secretion of cortisol. Physiological, it is a normal reaction. It will suppress normal secretion of cortisol. Then, next morning, we again measure cortisol. If cortisol is suppressed, there is no tumor. If no suppression, there is a tumor somewhere in pituitary or in adrenal gland. So then how to understand where is a tumor? If ACTH is low, this is adrenal tumor, negative feedback effect. If ACTH is high, it could be pituitary tumor or ectopic ACTH producing tumor. How to understand this is ectopic or pituitary before imaging, before MRI or CT scan? We can do second test. It is called high dose dexamethasone suppression test. The same as low dose. Morning time we measure cortisol, and then in the evening we give high dose of dexa, usually 16 mg of dexamethasone. Then at 8 o'clock next morning, we again measure plasma cortisol. If there is suppression, it is a pituitary tumor. If there is no suppression, it is an ectopic ACTH production tumor. Why it is so? Because tumors of pituitary gland, they are more sensitive to peripheral hormones than ectopic tumors. Ectopic tumors are usually malignant tumors. Next, our next step will be imaging. You see, we always do our diagnostic pathway by step, not all together everything. You may do MRI of pituitary. Better if you want to see pituitary gland, better to do MRI. If you want to see adrenals, better to do CT. But one of the best type of test, as in previous topic, it is a PET, positron emission tomography. Down part, look, imagine with D3 electrolyte. It is a PET, positron emission tomography, can identify very small tumors in the whole body. So we are here is pituitary tumor, big pituitary tumor. Here is by arrows mentioned a various localization of ectopic tumors which produce ACTH. So please make a screenshot of this differentiate diagnostic scheme. What we will do in that situation is, of course, because it is a tumor, we need first of all to do surgery. Not endocrinologists. Who will do that? Neurosurgeons. If it is pituitary tumor, you will send your patient to highly qualified neurosurgery. And this true treatment will be intranasal neurosurgery, or another name, transsphenoid adenopectomy through the nose. So how does it look like? Okay, please make a screenshot of these side effects. This type of treatment is safe. Very rare to see such side effects. Sometimes may present permanent side effects like diabetes, insipidus, hypopituitarism, but it depends on qualification of neurosurgery. Through the nose, endoscopic surgery, intranasal or transsphenoidal adenopectomy. Through the nose, these surgeries is required. That is so. If your patient has adrenal tumor, then it should be laparoscopic surgery. It is laparoscopic surgery. The treatment, it's a treatment of choice for unilateral adrenal adenomas. The second way of treatment, pituitary irradiation. Pituitary irradiation. It is a high energy ionizing radiation, which is delivered to deep tissue by different techniques. What could be used? Gamma ray, gamma, it's a short nuclear rays, and proton rays. They destroy tumors locally without, very rare, without injuring surrounding tissues. We also can use medications, which are called cortisol inhibiting drugs. Cortisol inhibiting drugs. They are ketoconazole. This is antifungal drug, but in high dose, it may suppress cortisol. It will suppress cortisol very effectively. Metirapone, aminoglutamide, mitotane, and etimidate. We usually use the drugs for treatment of complications of Cushing syndrome. If you need to prepare a patient before surgery to decrease osteoporosis, to decrease glucose level, to decrease adrenal blood pressure, we may suppress cortisol with the help of cortisol synthesis inhibitors. But there is no influence of these drugs on the tumor size. They do not affect on tumor size, and it's not a basic treatment of Cushing syndrome. That's literature. So Williamson textbook of endocrinology. It's a main book which you should read. I will send you it in the end of all lectures in the group which you created. Link for Google Disk with that book and another materials. And next, as opposite to this condition, is Addison disease. Addison disease is a situation when cortisol level, adrenaline level is low. So it is very low and may provoke emergency situation, which is called adrenal insufficiency. So do you see my screen?
Yes, ma'am.
Yeah. Come back again to adrenal hormones, cortex. It is adrenal cortex and insufficiency. It produces 3 types of hormones. And the hormone, which is most important, it is aldosterone, because aldosterone controls blood pressure. Now you don't know what you are doing, maybe sitting, lying, eating, walking, but you have a stable BP. It happens because of one of the regulating factor. One of the most important regulating factor is the aldosterone level. Aldosterone regulates sodium potassium balance. It saves sodium in blood, saves blood volume, constant blood volume in the body, and saves water in our blood. According to this, we have normal level of blood pressure. In adrenal insufficiency, it doesn't work. Level of aldosterone is low. Cortisol is also low, but without cortisol, it's possible to live. We need it in stress moment. Severe stress, we will not see big problems in the deficiency, but without aldosterone, it's impossible to have normal blood pressure. Sodium, retention of potassium, and reduced of intravascular volume, lowering of BP. According to this, we have 2 types. Come back to hypothyroidism topic. Same like this condition, we classify it in 2 types, primary and secondary. Primary, it is a destruction of adrenal cortex. According to bleeding, surgery, antibodies, autoimmune, genetic disorders, like in child's congenital hyperplasia, it is called, but don't look at the name. The symptoms will be adrenal insufficiency symptoms. And using of some drugs, especially ketoconazole. If we overdose it, we may see suppression of aldosterone activity. Secondary, it is a pituitary diseases, damage of anterior pituitary gland and damage of ACTH production cells. In primary adrenal insufficiency, we usually see destruction of all 3 layers of adrenal cortex. No cortisol, no aldosterone, no androgens. In secondary, we usually see only ACTH deficiency, So remember regulation. Without GCTH, no cortisol, but renin and aldosterone is present. So secondary adrenal insufficiency is less severe than primary. Primary insufficiency, more severe. Again, that difference, please read primary, secondary, tertiary. What happened here? In all of the cases, you will see loss of steroids, but causes are different. So differentiate diagnosis. I want today to speak about primary adrenal insufficiency mostly. It's another name of this disease is Addison disease or Brown's disease. It's most commonly in adult people is the autoimmune etiology, result of chronic destruction of adrenal cortex by autoimmune system. The same like diabetes, Hashimoto thyroiditis, primary hypothyroidism, hypoparathyroidism, adrenal insufficiency in adult people may develop due to autoimmune destruction. But people with adrenal insufficiency, if they have autoimmune problems, they also may have insufficiency of other hormones like hypothyroidism, diabetes mellitus type 1, hypoparathyroidism. In this situation, if we see combination of various endocrine diseases deficiency, we call it autoimmune polyglandular syndrome. Another causes include adrenal hemorrhage. Intra-adrenal hemorrhage, it may present in infection like meningococcal infection. In meningitis, people may have hemorrhage into the adrenal gland and acute adrenal insufficiency. Tuberculosis also. Well, actually, Addison described this disease in the end of the 19th century in people with tuberculosis, metastatic disorders, deposition disease, so like amyloidosis, sarcoidosis, using of drugs, and congenital adrenal hyperplasia. It's another cause. Causes of secondary adrenal insufficiency could be pituitary damage or chronic exogenous glucocorticoid treatment. What are the symptoms? Low blood pressure is the main symptom. Weakness, tiredness, fatty symptoms, nausea, vomiting, abdominal pain. Sodium is low, potassium is high. Diarrhea, salt craving. These people, they like to eat everything salt. They have postural dizziness. They may have muscle or joint pain because of potassium elevation. They usually have weight loss, and very specific symptom of primary adrenal insufficiency is the hyperpigmentation. People have vitiligo, people have hypoglycemia, especially in adults, electrolyte disbalance, hyponatremia, hyperkalemia, azotemia, and eosinophilia. Secondary adrenal insufficiency is hypothyroidism. Secondary hypothyroidism may present with the other pituitary hormones disbalance, insufficiency. Well, and that picture shows you classical hyperpigmentation on gums, elbows, on the low part of the screen, right part of the screen. You see white spots. That is vitiligo. Vitiligo is a symptom of autoimmune disease. Vitiligo is an autoimmune depigmentation of the skin. Also here, pigment. Why it is so? Why pigment accumulated? In primary adrenal insufficiency, when the level of cortisol decreased, pituitary gland tries to stimulate secretion of cortisol, increase ACTH, increase MSH, and pigment formation. If we don't treat it in correct time, in correct way, and in the quickly time. People with adrenal insufficiency may have adrenal crisis with dehydration, hypotension, nausea, vomiting, loss of fluids, fever, hyponatremia, hyperkalemia, heart arrhythmias due to this. First of all, these people, they have severe loss of blood pressure, hypotension, and cardiovascular shock. If it is severe loss of blood pressure, level of blood pressure decreased, kidney function decreased, people may die from kidney failure, brain encephalopathy, brain edema, and heart attacks, heart arrhythmias. So, diagnosis. What we will do for diagnosis? We will examine cortisol level and aldosterone level, of course. Look at the right part. If you examine STH, if you see that if it is low, this is pituitary problem. If it is high, it is adrenal problem. But emergency treatment, we will start according to the symptoms. We do not wait of a laboratory test. So baseline, if you see cortisol level less than 3, cortisol level less than 3 shows you decreasing of shows us decreasing of its function. It is a specific symptom of adrenal insufficiency, and it will. This is our diagnostic test. If you want to prove that it is there is also aldosterone deficiency, you also may check aldosterone, but sometimes no need to do that. ACTH level, primary and secondary, different situation. Primary, it will be high. Secondary, it will be low. Also, this is the summarizing of the lecture. In treatment, in acute, you will use mineralocorticoid, which is a hydrocortisone every 24 hours IV, plus simple saline solution, because people, they have low level of sodium. You need to give them sodium IV, high volume, 1 liter per hour. Chronic adrenal insufficiency. When it becomes chronic, then we need to treat it by hydrocortisone orally and maybe prednisolone also orally, or fludrocortisone. If it is primary, we usually combine mineralocorticoids with glucocorticoids. Usually it's better than to give only one type of drug. If it is primary, you should understand that there is a deficiency as cortisol, as aldosterone, as mineralocorticoids should be given, as glucocorticoids should be given. So is it clear? Do you have questions? Or as usually, no questions, no comments, no questions, yes?
Maybe we will discuss in practice class.
As usual. Then let me start. I think we have. Do you need rest, or you anyway you have rest? Do you need rest? I'm asking. Whom I'm asking? Do you need rest or not? Or we may continue.
We can continue.
And others, what do they think? Or they don't care? So,
Ma'am, continue.
Continue. Okay, next is acromegaly. Also, this is not a big lectures, and diabetes insipidus also short one. Then let's finish our lectures. So. Also, disease, I don't remember when I see it last time. Acromegaly is a condition, another type of tumor of pituitary gland, growth, which is based on the growth hormone. Do you see my screen?
Yes, ma'am.
Hormones: ACTH for adrenal cortex, MSH for pigment, growth hormone for bone, muscle, and internal organs growth, TSH for thyroid. Here there is one mistake. Gonadotropins, they are from, of course, pituitary gland. FSH from testicles and ovarium, ADH and oxytocin from for kidneys and breast regulation. So the secretion of milk during breastfeeding and constriction of smooth muscles. So growth hormone problem with the growth hormone is called acromegaly. That is disorder where the level of pituitary gland produces too much of growth hormone. It's a dangerous disease, rare but very dangerous. How it happened? Pituitary adenoma produce too much growth hormone. It stimulates secretion of insulin-like growth hormone. In liver, there is a factor which stimulates growth of other cells. It's called IGF, insulin growth factor. It is mainly produced in liver and responsible in growth of the various cells and tissues. So growth hormone produced and secreted in pituitary gland. IGF, insulin-like factor, produced in liver in response to growth hormone. Somatostatin is a hormone produced by hypothalamus, which inhibit secretion of the GH, of the growth hormone. Remember, please, all these 3 key points. They will be important in treatment of this disease. We have 2 types of tumors. Pituitary tumors, in classification, tumors which are present in pituitary gland, and like in Cushing, extra pituitary tumors. So non-pituitary tumors, in people with acromegaly, tumors may present in extra pituitary cells. As in Cushing, it's usually lungs or pancreas. Lungs cancer or pancreatic cancer may secrete tumors with the growth hormone. May secrete growth hormone. These tumors, tumors of pancreas, tumors of lungs, sometimes they may secrete growth hormone. In this picture, you see the basic types and these tumors, how they look like, what types of tumors, according to biopsy, may present in various organs. This is acromegaly. Everything growth hormone is high. In children, it is also acromegaly. Do not think that in childhood we call it giantism, and adult people we call it acromegaly. It's always acromegaly, but in child, if it is started in childhood, children they have a giantism. Giantism, it's just a symptom. We will speak about adults. Adult people, they if disease start in after closing of growing areas in bones, the bones, they cannot grow anymore, but soft tissues, they can easily grow all life. So main symptoms include acral enlargement, maxillofacial changes, arthralgias, headaches, visual defects. This we also call these people, if you look at them, also possible to understand that they have acromegaly, so they have Greek extremities, means big hands and big legs. In child's, bones can grow. In adults, bones do not grow. Then you may see facial changes, enlargement of jaw, enlargement of nose, enlargement of tongue, teeth space becomes spread out, so teeth spread out. Joints also grow, pain in joints as well develop. Voice become very deep due to the growth of the vocal cords. People have sleep apnea due to the growth of the epithelium of bronchus. Skin become very oily. Blood pressure increase due to the growth of the endothelium of vessels. Patients also have headaches because of tumor effect. So tumor, usually these tumors are big one. They compress surrounding tissues. People may have hypopituitarism because these tumors suppress other hormones. They may have enlargement of internal organs like liver, hepatomegaly, splenomegaly, goiter, hypertrophy of colon, megacolon, polyps in colon, kidney stones, heart enlargement, so heart megaly, cardiomegaly, hypertension, and finally cardiomyopathy. You see, symptoms are very dangerous. The people also have metabolic disorders, severe diabetes. It is also secondary type of diabetes, not type 2, secondary type with insulin resistance. They have visual changes because tumor compress optic nerve. They may have thyrotoxicosis because thyroid gland enlarged. They may have galactorrhea because prolactin also enlarged in this situation. If you look at this picture, this woman, slowly progression of acromegaly, how appearance change during the last 10 years. It's another picture. You may find on the internet a lot of pictures with these people because this disease is rare and possible to show you only on the photos, this condition. Body enlarged, organs enlarged, extremities enlarged, everything grow. What we will use for diagnostic test? We will use, of course, growth hormone blood test, oral glucose tolerance test, but not for diagnosis of diabetes, CT scan, visual field examination, and MRI scan. Visual field examination on the upper picture, normal vision, on the down picture, how people look like, if, what do they see if they have pituitary tumor which compress optic nerve. Growth hormone. If growth hormone less than 1, it is excluded condition, but better to check insulin-like growth factor. IGF test is the best of the best for diagnosis of acromegaly. Then oral glucose tolerance test. Why do we do? How it is provided here? Please pay attention. If you do not, if you tell me on the practice that you use it, we use it for diagnosis of diabetes mellitus and acromegaly, it means that you did not listen to the lecture. Because OGTT we use in people with acromegaly to examine the level of growth hormone before and after taking of sweet solution of glucose, because glucose suppress the level of growth hormone in health organism. When we give 75 grams of glucose and examine growth hormone after 30 minutes, the level of growth hormone should be suppressed. If it does not happen, test is positive if growth hormone level does not fall below 1 ng per milliliter. MRI shows us tumors because these tumors are big one and easy to find them on MRI examination. Pituitary adenomas, these adenomas are usually large adenomas and compressed surrounding tissues. So there are many extreme celebrities with acromegaly, especially in sportmen who among boxers. If you are interested, you will search on the internet information about them, and you'll see how many people in sports had acromegaly. Not because of sport, just it happens that they have higher results because of acromegaly, because they have high height and they become a little bit more successful. But unfortunately, chronic acromegaly will provoke different changes in internal organs, growth of the old cells and also malignant cells. And so these people have a high chance of death due to the malignancy. Also, extremities of patient with acromegaly. On X-ray here, you see how soft tissue is enlarged. What will you use in treatment? Of course, first and the best is surgery, then medical treatment and irradiation, same as in Cushing, but drugs are different. So you see, surgery, also transcranial adenopectomy, medical, somatostatin analogs, dopamine agonists, and antagonists of growth hormone receptors, radiation, gamma therapy, and stereotactic radiosurgery. Somatostatin analogs, what we can do as an endocrinologist, we can give this independent method which can suppress tumor size. Dopamine agonist, possible to use if tumor produces two hormones, growth and prolactin. Antagonists of growth hormone receptors, pegvisamat, could be used on the to suppress peripheral effect of the growth hormone without effect on the tumor. Usually, we use it before surgery to for quickly normalizing of quickly control of symptoms. And surgery, transcranial surgery, the modality of choice. As I showed in Cushing, the same like in Cushing, through the nose, it is provided. Radiation, highly ionized radiation can destroy locally tumor cells. How it look like? Can we prevent acromegaly? Unfortunately, we cannot. We cannot prevent it. We cannot do anything. It is a genetic disease. So that's why better to treat these people in the early period of time, because it leads to disability and earlier deaths. Prognosis, if we treat them, very good. If we do not treat them, prognosis is poor. It increases premature deaths. That's acromegaly. Hope you will never see it because it's really difficult to treat these people. Treatment is expensive, treatment is difficult, and sometimes people should live all life with this disease, and they may have big problems according to this disease. So, well, and actually, final topic, diabetes insipidus, and you may have rest for today. This topic will finish my lectures. We already discussed diabetes mellitus. That is diabetes insipidus. Absolutely absolutely different disease than diabetes mellitus. Connect with ADH, antidiuretic hormone. What is it? The antidiuretic hormone, it controls water loss. That's why it's called ADH. It controls water loss, stimulates reabsorption of water by kidneys, and also little bit increased blood pressure. Diabetes insipidus situation when there are two symptoms. Person has dilute urine and constant thirst. So polyuria, polydipsia present. The same like in diabetes mellitus, but reasons are different. Look, there are 4 types of diabetes insipidus. Central or pituitary deficiency of ADH. Nephrogenic, peripheral, low response to ADH in peripheral kidney tubes. Gestational or transient diabetes insipidus in pregnancy, because placenta produces too much enzyme, which is called vasopressinase. Not in all pregnant women, but in some may present. And primary polydipsia, if we start drinking a lot of water, our pituitary gland stops secretion, it doesn't secrete thalamus, stops secretion of ADH. This picture is very good. It shows you all types of diabetes insipidus. Central, it is pituitary deficiency or hypothalamus deficiency, primary polydipsia, excessive fluid intake, gestational diabetes insipidus, placenta vasopressinase secretion, renal, nephrogenic diabetes insipidus, decrease the response of the receptors to understand that it is ADH and to concentrate urine. The cause of central diabetes would be the cause. Genetic defect, no secretion of ADH in hypothalamus. Some diseases, like you see here, one of the genetic diseases called Adrenal syndrome, connection with diabetes insipidus, diabetes mellitus, optic atrophy, and deafness. Some hypothalamic disorders, more common among adults, the most common cause of diabetes insipidus is a post-surgical diabetes insipidus in people who had any tumors of pituitary gland. Craniopharyngiomas, pituitary tumors with the after surgery, basal meningitis, head injury, and idiopathic. Usually idiopathic is the autoimmune diabetes insipidus. Nephrogenic diabetes insipidus, more common. It could be also genetic defect of receptors. It could be using of the drugs like lithium, which is used in psychiatric diseases, and loop diuretics. We do not use furosemide for a long time. Metabolic abnormalities like hypokalemia, hypercalcemia, hyperparathyroidism, today a radio. Also, people have polyuria, polydipsia, and intoxication with heavy metals, poisoning, especially with mercury. Mercury damages receptors to ADH. Features include polyuria, polydipsia. Why it is called diabetes insipidus? Polyuria, polydipsia, the same like diabetes means polyuria from ancient Greece. But mellitus, why it is called in this way? Diabetes means polyuria. Mellitus means sweet urine. Insipidus means dilute urine. In ancient times, how people understand this is mellitus or insipidus. If people had sweet urine, the doctors, they tasted it or use ants. If it was diluted like water, it was insipidus. What you will see in diabetes insipidus, you always will see low specific gravity of urine. Problem is, this is central or this is nephrogenic. In this case, we can do vasopressin or ADH administration test. Kidney will respond in cranial form, and if it will not respond, if it is nephrogenic type. Easy to put diagnosis, actually. In diagnosis, so we usually don't have any problems. So in treatment, you will use desmopressin if it is cranial form. This is artificial ADH. In nephrogenic, we may use thiazide diuretics. They increase sensitivity to ADH, and carbamazepine. It is also increased sensitivity to ADH. And actually, I'm finishing. Don't tell me that I didn't read your lectures, please, on practice. And don't tell me that don't tell to the other teachers that. I know how students do. You come at the practice class, you are coming to practice class, you didn't read anything, and you tell to teacher, we didn't have lectures, please. It is not correct. You had lectures, I will send you materials before practice classes, not today, before classes, I will send you materials. Please prepare. Do you have any questions? Any questions?
No, ma'am.
If no questions, then please send me once again a list of absent students, because I see only 36 participants. I understand that maybe most of you are not listening, but anyway, connect is very easy just to connect now, because I also make screenshots of the screen and I can understand who is here, who is not. Thank you. See you in your practice classes.
Thank you, ma'am.
До свидания, ma'am.
It's brilliant.
Mm-hmm.